Okay. Good evening, everyone. I welcome all of you for the IAS Academic Corner meeting for the month of December. This is happening for almost last 2 years. And I thank all the members of IAS and also other members who are viewing this every month. And we have a lot of experts today. We have holders and
Good evening, everyone.
And I welcome Dr. Atik Wasdev. We know that he's a well-known national faculty. He is going to moderate. And also we have Dr. Rudra Prasad from Bangalore. He's a good friend of mine. He is a senior arthroscopic surgeon from Bangalore. And both of them are going to take over these proceedings today. Thank you, Atik and Rudra.
Thanks, Sundar.
Thank you, Sundar.
Rudra, why don't you introduce the first speaker?
No, I think introduction will be done by.
Yeah, it's okay. Rudra, you can. Okay. Sujit doesn't need any introduction.
Yeah.
Introductions.
Okay, I invite Dr. Sujit now. No, I don't think he needs any invitation or any introduction. So Sujit is going to speak on techniques for anterior instability. So over to you, Sujit. Just one housekeeping thing. I think everyone can turn off the microphones if possible. So that over to you, Sujit.
Hello, good evening. Thank you for the kind words. I'm Dr. Sujit Jose from Cochin, who, for those who have not known me till now, I work in a medical college. I am the professor and head of the department there. And let's talk on the techniques for anterior instability. My special interest is in shoulders, and I do quite a few number of shoulders. Thank you, Dr. Sundar, Dr. Sachin Tapasvi, Dr. Sandeep, and everyone here for inviting me to talk on techniques for anterior instability. So, anterior instability and shoulder surgeries have been evolving over the past decade, and there has been an exponential increase of surgical expertise and procedures and changes which have happened in the last 5 years or 10 years, where we started doing good shoulder scopies. So recurrent episode shoulder dislocation causes the anterior edge of the glenoid to be worn off when the head rolls off. The glenoidal tear is what we deal with in arthroscopic Bankart. So we will deal with the Bankart procedure, the associated procedures in soft tissue anterior Bankart or capsular labral complex tear, and something about the bony anterior stability as well. So those are the instruments who are doing shoulder scopy will know the switching sticks, the dilators, the cannulas, the instruments, the cutting instruments, the suture retrievers. That's the most commonly used instrument I feel in shoulder scopy. The graspers, the toothed one, the flat one, the elevators, the RAS, the curettes. These are all instruments which we require for anterior stabilization. The high volume or the heavy instruments we need are, one is a shaver. More than that, the radiofrequency ablator is commonly used in shoulder scopy. That is a must when you are doing shoulder arthroscopy. Otherwise, you can get stuck in between with the bleeders. Then an arthroscopy pump. This is optional. I use pump for all my scopies, whether it be knee, shoulder, wrist, hips, or ankles. The shoulder pump is a boon. I say I have good control over the pump pressure, the pressure of fluid inside, and I don't have to fight bleeding inside when we have a pump. So you can set the pump settings, the pressure and the volume of flow of water can be adjusted. And a good anesthesiologist is important when you start shoulder scopy. The hypertensive anesthesia is very important. It is less of a problem in shoulder instability surgery than in rotator cuff surgery, because the shoulder instability is done inside the capsular, the envelope inside the shoulder. So the decision making and the other things have been talked by the previous surgeons. Dr. Ashish Babulkar had talked about the theory part and how to make a decision. He is the master of decision making. Yes. Let's talk about start with the positioning in the techniques. So I prefer the lateral position, where you can give a good lateral traction as well as a distraction with a lateral post. A longitudinal traction is important. This can be done when I started my shoulder work. This was how I was to do. This is equally good, the same, the cannulas and the position of the patient. This position is good for the neck of the surgeon, especially. You don't get the aches and cramps in the back of your neck, especially when you're working on the same plane. So advantage of lateral position, it gives ease of traction. You can view the glenoid as a flat bed, and you can do the repairs all around the bed, just like making the bedding in a bed. The glenoid will be parallel to the floor. Keep the patient in a slopey lateral position with about 20 degrees of posterior tilt, which gives you the best view and the less stress in the surgeon's neck, as I already told. Surgical markings, let's start with that. The spinoscapula, the acromion, the clavicle, the coracoid are marked. The viewing portals, working, and the suture management portals. Mainly in shoulder instability surgery is the posterior portal, the anterior portal, and the anterior superior portal. 3 portals important in a Bankart surgery. And you have the accessory portals, the mid glenoid portal for Bankarts, or anterior inferior portal, the 5 o'clock portal for placing an anchor more inferiorly if you don't have the curve instruments, or you want to reach more inferiorly, or the opposite side maybe. The posterior inferior portal, the Wilmington portal, which we use mainly for slap repairs, especially the posterior part of the slab, or the Nivasier, the superior portal, which is not used now much because the rotatic cuff repairs are done with self-retrieving instrumentation. Or now I use it only for the suprascapular nerve decompression in case of a compression there in the suprascapular notch. Instability of Bankart surgery, these 3 are the main portals: the posterior portal, the anterior, and the anterior superior portals. So the viewing portal should always be the anterior superior portal. I've done the mistake of trying to view from posterior. I'll come to why it should not be used, at least in my sense. Let's go through the other portals. The 5 o'clock portal, this is used maybe for the inferior anchor, as I said, or for haggle repairs. When there is a humeral avulsion, you can use this portal to reach the upper end of the inferior glenohumeral ligament attachment. The posterior inferior portal, again 7 o'clock portal, just for understanding, that's also there, but I've never used it or seldom use it. Wilmington portal there, it's located about 1 centimeter anterior and 1 centimeter lateral to the posterior acromial angle. It provides access to the glenoid and superior labrum, mainly for slap repairs. The Nivasier, as I already said, it goes through the supraspinatus. It's about 3 centimeter medial to the superior portal, to the superior portal at its closest point. Suprascapular nerve is nearby, so you can do a release of the nerve with using the anterior portal. This used to be very commonly used in suture retrieval devices, when the non-retrieving punches or the scorpion-like device used to be used in yesteryears. Now for SS and decompression. The lateral portal, mainly for rotator cuff repair, and not under purview now. The posterior portal, the first portal which has to be made is a posterior portal. That's usually made about 2 or 3 centimeters inferior and 2 centimeters medial to the posterolateral tip of the acromion, between the infraspinatus and teres minus, where the instruments go in the soft spot. Basically, you have to feel the head, pull it out with your hand, and make the portal there. That makes it very easily and direct towards the coracoid when you start. So that's where the posterior portal lies. So making the posterior portal, this is a 10-year-old video. I used to start with the needle and insufflation of the joint with saline, which helps you distend the joint and makes the entry of the scope much easier. This can be followed, or if you are quite confident this is not required, you can directly go in with the hemostat to puncture the capsule and the blunt trocar to go in, and you can feel the pop when the instrument goes into the joint. That's the pop. Hope you can see the video. And that's the lateral portal and the traction. As I said, it's an olden video. Now I use a spider for traction. So the cannulas. Cannulas are very useful, especially in the anterior portals, the anterior and the anterior superior. Posteriorly, that's not required unless you are tying a knot from there. The cannulas, when you select, when you order cannulas, there will be 2 types of cannulas, the 70 mm one and the 90 mm one. Never take the 90 mm in Indian patients, that's seldom required, because the length is too much. Your instrument's length won't be enough to traverse the 90 mm scope and to do a repair or a work on the other end. 70 mm length is good, and 2 cannulas. I use one in the anterior portal, the 8 mm cannula, which is the working portal anteriorly, where the instruments have to go in and take bites, and the 6 mm or a 5 mm portal in the anterior superior portal, which should be the viewing portal. That's and the helping hand. You should train your surgeon, assistant or your nurse to hold the cannula when the instrument goes in and out, because the cannula can move. And one tip where you insert the cannula is, over a switching stick you use a dilator and make the incision 1 millimeter less than the cannula you're trying to use, and stretch the skin and stretch the tissues to go in, so that the cannula stays in its place, and always rotate and go through the threads. And that's the cannula being used for surgery. So let's go to a case. Let's start with the case, how you manage this. A 26-year-old bank employee, recreational athlete. He plays badminton, dislocated shoulder while playing football 8 months back, then close reduced by the emergency physician, rested for 2 months, redislocated again while playing badminton, and now he's very apprehensive in abduction and external rotation movement. Those are the MRO reports. You can see the Hill Sachs lesion already there in the axial view, and the anterior labral tear. Hope that is visible on the screen. You can see that the labral tear and the coronal image, where you should look for slab tears, which is not there. You can see the triangle of the superior labrum there, and these are good views where the sagittal view can give you an idea about bone loss that's happening in the anterior glenoid. So how to proceed? A CT scan is done, a best fit circle is applied to a 3D reconstruction. I always get this done, both shoulders, and the end-on view, you never go wrong. You have the visual impression. Never go for the CT cuts, the MRI cuts. They all are very much technician dependent. Unless you take a cut parallel to the glenoid face, those can go wrong. This gives you a very good visual impression, and the bone loss is calculated as around 16% here in the anterior glenoid, the best fit circle, and the Hill Sachs, you can see it's around 17.1. So it's a slightly off track with 16% bone loss. And a recreational athlete, a person has crossed 20s or 25, so I plan to go for an arthroscopic bank cut procedure with a remplissage because of the off track nature. Hope you're all aware of the on track and off track. So when the Hill Sachs index, that is the space between, the distance between the attachment of the infraspinatus to the medialmost part of the Hill Sachs, when it is wide, you go for a remplissage procedure. So first let's start with the making of the portal. This is the right shoulder. You can see that is the subscapularis, and on your right side is the long head of biceps and the humeral head there, and the glenoid is flat. We are viewing from the posterior portal. So that's the needle, and then followed by the switching stick. You have to be as inferior as possible in the rotator interval, that is the space between the subscapularis and the supraspinatus, and an 8 mm cannula comes in there. Yes, that's done. And then the superior most part of the rotator interval, you make the next portal. That can be just grazing the supraspinatus. It can come sometimes anterior to the biceps tendon. Usually that's the way, and here it is coming posterior to the biceps tendon. That doesn't matter. Basically, you need to have a vision from the top, and you should not injure the supraspinatus. And next, you can see the torn hammock. There, the IGHL, the inferior glenohumeral ligament, is very loose, and you can see the anterior part of the glenoid, where the labrum, which should normally be attached there, is not as much visible. Then the diagnostic round, you go up and view towards the upper part of the humeral head. There you can see the Hill Sachs lesion, that is the posterior aspect of the humeral head. That's very well easily visible. And in this, at this point, you ask your assistant to push the humeral head a little anteriorly. You give an anterior thrust, the Hill Sachs comes into view very well. That's the Hill Sachs remplissage. When you have a plan of a remplissage, you start with the remplissage anchor insertion first. And remplissage, how I do it, view from the anterior superior portal, not from posterior. You can do it by viewing from the posterior, but then you have a risk of the scope slipping out multiple times. So you switch the scope from the anterior superior. You can very well view from looking to the side. You can see the Hill Sachs lesion very well, as you will see now. That's the Hill Sachs portal. A slight anterior thrust and external rotation. A 30-degree scope is enough. So if you have to view it with a 70 degree scope, that Hill-Sachs does not need to be addressed because that's too inferior. Anterior superior Hill-Sachs lesion will be visible with a 30 degree scope. That is a remplissage portal, which is about 1 to 2 centimeter posterior and lateral to the posterior lateral corner of the acromion, and there you can see the real posterior portal. So that is there just across the edge of the acromion. That's the view from anterior, viewing the Hill-Sachs. It's exactly like we saw from posterior. So that's the Hill-Sachs lesion. The needle coming in, the hemostat used to dilate it. I use a cannula to start with. You can use a 6 mm cannula for using the instruments to clear or make a bleeding fresh surface of the Hill-Sachs lesion. There, that's the cannula inserted, and that's the curette coming in to clean the soft tissues or the muck over the Hill-Sachs, and the shaver to clean it off. You can see the bleeding surface, and then the insertion of the anchor. Here all suture anchor is being used with fiber tapes, double loaded, and I don't insert this much towards the edge. If you insert it towards the medial edge of the Hill-Sachs, you have a risk of over constraining the shoulder. So try to exteriorize as much as you require to exteriorize, not too much. And these the two instruments I use. This is a slingshot which I use very commonly. This is an instrument I love to do remplissage with. It works very fast. Or you can use a bird beak direct suture penetrating suture retriever device. So that's the suture management. The anchor is already in. You can see the double loaded anchor with 4 tapes, and the threads are all coming in through the same hole. You withdraw the anchor, and then I'm using the slingshot here to take bites from different parts, one inferior, one superior, one towards the glenoid, one medial. And you spread out the threads. That's the slingshot, and the bites coming in. It's got a retrieving tip. It's a very useful instrument. I love this, the medial, lateral and straight, left, right and straight. 3 types are there, and it's multiple use. I've been using it for maybe 3 years now. That's it coming in. Depi also has a similar instrument. This one belongs to Stryker, and that's it. It's quite simple, and the threads are retrieved from different areas, spreading out so that the infraspinatus and the capsule will be bunched when you tie these knots at the end of the procedure. There you can see the threads are all spread out now through different holes. One thread can be left, or the tape can be left in the hole through which you came in. 3 other bites, and you're done there with the remplissage. The tying of the knot is done at the end of the procedure, that is after your Bankart repair. You can use different methods. There are 2 anchor methods. You can either also use a double pulley method. You single loaded 2 anchors and tie them one over the other, but this technique works fine for me. I take hardly 15 minutes to do that. And that's the Bankart repair, viewing from the anterior superior portal. You can see how beautifully the anterior edge of the glenoid is demonstrated here. You can see the bare area of the glenoid, and with the probe itself I can get the labrum to be detached there. And working portals are the anterior and posterior. That makes your life very clear and simple. An 8 mm cannula in the anterior portal, 6 mm in the anterior superior portal. There is an optional cannula you can use in the posterior portal as well, but posterior you don't require a cannula because in and out usually comes quite comfortably, and the water leakage is much less. Sliding knots, you can use either a Duncan, which is a non-locking, or a Western locking knot. If you have a tension in Bankart that's not required, you can use a hangman's noose or a sliding knot which secures well, and secure with 3 alternating half hitches. And wherever you are, the knot has to be properly made, otherwise it can come loose. That's the Bankart repair. You can see the anterior labrum being freshened, and the elevator being used to delineate the anterior tear. It comes from around 2 o'clock up to the 6 o'clock position. That is a measuring device. You can recheck your measurements in CT scan here, and that's an elevator. You can see the labrum well elevated, and the anterior glenoid being freshened with a rasp. And avoid placing the anchor onto the face of the glenoid. Always keep it at the edge, and viewing of the edge you can see only from anterior superior. You will make mistakes when you are viewing from posterior when you are trying to do a Bankart. I have made that mistake. The anchors can skive off because the glenoid is like a ledge. You have to keep it at the edge, not onto the face. Onto the face you can keep insert by viewing from posterior, but onto the edge you can keep only, that's the anchor positions being marked. This is very useful step, because after placing the first and second anchor, you will get confused how far you have to come superiorly. So mark the 3 points, the 5:30, the 4:30 and the 3 o'clock, so that you have easily visibility of the anchors. Here in this case, I'm using a Mason Allen stitch with a double loaded anchor for the inferior most anchor. That's a indirect suture passing device, the Acupass being used there, and that's the thread and the retrieval. I'm using a portal posteriorly as well for demonstration purposes and the ease of passage. So Mason Allen stitch, you pass through 2 stitches initially as a mattress, and then a simple bite with the third suture, and the mattress crumbles it. So you get a good inferior capsular shift when you do a Mason Allen for the inferior most. Whenever I see ligament laxity, when the ligaments are slightly loose in younger persons with a large Hill-Sachs lesion, double loaded Mason Allen is a good technique to add extra strength or tightness in the inferior most anchor fixation point. So you can see the first knot being tied, that is a horizontal mattress, the mattress suture, and then the single being tied, and there you can see the capsule already bunching up onto the anterior. And don't aim for just a pump, don't take too much of a bite, just take enough tissue to recreate what has torn. Don't take too big a bite, which also can cause more trouble sometimes, or constraining of the external rotation. So you are trying to recreate the torn inferior glenohumeral ligament to the edge of the glenoid. That's a remplissage knot tying. There, the 4 sutures, and they are just tied blind. You don't have to look inside. If you want, you can inspect afterwards, after the Bankart repair is over, and you can go with the feel, and you can tighten over the soft tissues. And few other things you have to be careful about. One is a lesion here. Can you appreciate that? That is a Hagel lesion. So always look up. That is, inferiorly we are viewing to repair the labrum to the glenoid. Superiorly it might be detached from the humeral head. That's a Hagel lesion, or a humeral avulsion of the glenohumeral ligament. This is called a floating IGSL. This is not very uncommon. It's not very common, but then it is not very uncommon as well. You can use a 5 o'clock portal for reattaching. That's a 5 o'clock portal where you access the anterior part of the humeral head and insert an anchor there. That's the Hagel repair being done, needle coming in, and the anterior part of the humeral head being freshened, a burr being used there, a double loaded anchor, and again a Mason Allen stitch is being used. Again the slingshot comes in and makes your life quite easy to do the Hagel repair. So after you tighten it, you can see how well it is approximated, and you have a good tight anterior side, which will prevent a late dislocation. That's a patient afterwards. You can see the 5 o'clock portal there and the stability. Another thing in anterior stability is the slab test. So Hagels and slab can be missed in MRI reports unless the radiologist is very careful and very experienced. They may not report this, or unless there is an arthrogram being done, a slab tear also can be missed. So you have to be prepared. So that's the superior anchor coming in, superior part of the glenoid here, the anchor from the anterior superior portal, and the Acupass, or the indirect suture passing device, the curved one, to take the bites under the labrum, and retrieving the sutures, and the knots are tight. They shouldn't be too tight. Avoid penetration of the labrum, I feel, because labrum is a very sensitive structure. The biceps, the long head and the superior labrum are very sensitive, and they can be a source of pain post-operatively. That's the Bankart and the slab being done. I use a double load anchor superiorly to stitch posterior and anterior. If you're using a single load anchor, stitch only posterior there, and then one more anchor can be added posteriorly. You can use the Wilmington portal if that is required, or the posterior portal. There's another patient, a 25-year-old male, arthroscopic Bankart done 5 years back. He redislocated after falling from a height, and then again multiple episode dislocation. You can see the wasting of the deltoid. He was a bodybuilder, not by profession, by recreation. You can see the Hill-Sachs lesion here, which is significant. That's an internal rotation AP view. And that's a CT scan. When you compare with the opposite side, you can see a bone loss there and a large Hill-Sachs lesion. Another patient. The glenoid bone loss was measured as around 20, and the track was 23, and the Hill-Sachs index was 26 mm. So that is more than the glenoid track. Again, is an off track with a significant bone loss. You touch 20, you try to go towards a bony procedure. That's a Latige, which can be done, which is done now commonly by many surgeons as an arthroscopic procedure. That's a double cannula instrumentation, the Depumitek method. That's the Latige, coracoid preparation. Dr. Sandeep, if I'm crossing my time, please do tell me. Another couple of slides and it's done. That's
it's okay, Sujit. Yeah.
Yes, thank you. Thank you, Dr. Sundar. And that's the alpha beta guide, the coracoid being prepared, and the coracoid graft with the attached conjoint tendon being attached to the anterior glenoid. You can see the anterior part of the glenoid, which is having a bone loss. That's the bare area of the glenoid, and the recreated anterior glenoid with the coracoid graft. That's the postoperative X-ray. And the CT scan, you can see the best fit circle you can draw, and the anterior part of the lost glenoid is brought back. So just a word about the all fiber Latige. That's the engaging Hill-Sachs lesion when you do a neighbor on the table. And the coracoid prepared again, the two drill holes being made, the anterior glenoid prepared. I'm just brushing through due to lack of time. And that's the glenoid drill being used, the threads, the PDS and nylon sutures differently colored so that they don't entangle, and the cerclage tape being pulled from posterior to anterior and anterior to posterior through the portals. That's the tensioning device. And this has the advantage that there is no metal, and if there is an osteolysis of the glenoid, of the coracoid, the impingement of the humeral head does not happen. That's the capsulocerebral complex at the end of the procedure, and the coracoid graft is exteriorized. That's the CT scan, and the anterior glenoid being recreated, and it remodels due to the rub of the subscapularis. The coracoid graft remodels. And that's 6 weeks after arthroLatige, almost full range of motion the patient has. And as LaForce does, even a headstand is possible after 2 weeks. So that's the patient after arthroscopic Latige. So take home, management of anterior shoulder instability needs careful evaluation and good imaging studies before embarking on surgical stabilization. Otherwise, you could go wrong and the patient might stand on your head if the shoulder dislocates again, or if it's unstable. It may not dislocate, it may be unstable. So you have to give a good, strong repair, but it shouldn't be too tight as well. On-track and off-track concepts acts as a good guide to plan for add-on or bony procedures. Bankert is a simple and straightforward method. I prefer the lateral position, view from anterior superior, indirect suture passing device helping the inferior bite well. You can take a deep bite. The Mason-Allen stitch to give a better inferior capsular stitch shift, but that's optional. 3 or 4 anchor repair gives the best strength. And always look for add-on problems like a slab or a haggle, which can complicate your Bankert surgery. That's a patient who had a bilateral Bankert surgery. One side a remplissage also was done, and he's doing a headstand. He's a travel blogger, and he's doing a headstand at Himachal Pradesh when he was on a travel. He sent this to me, very happy that his shoulders are stable. Add a remplissage when Hill-Sachs lesion, and learn the remplissage technique well, and don't hesitate in doing it. Sometimes some surgeons feel it's a difficult procedure, and managing the portals, you get a good easy method of doing a remplissage. And shift to bony procedures when more than 20% of bone loss is seen on very athletic individual with significant bone loss. Thank you.
Excellent talk, Dr. Sujit. Really nice.
Thank you. Thank you. Thank you.
I think you covered all the basics.
Yes, please.
Anyone would like to ask anything?
Yeah, Sujit, just to add, because a lot of youngsters are watching your video, and then
yes, Dr.
have some doubts.
Okay.
Yeah, many may have many questions, but I ask you, what is the most important step in the whole surgery? What do you want to say to youngsters? Most important part of the surgery.
Okay, if you're talking about Bankart surgery, the most important part is to recreate the inferior hammock. The hammock has detached from the inferior glenoid to build back the strength, as well as not tightening it too much is the most important part. And then talking about the technique, the freshening of the anterior glenoid, I would say, is one important step. And don't take too much of bone. I've used the curate there, but that curate should be used only at the edge, not on the top. And attaching it to the edge of the ledge is very important. The glenoid ledge is there; it goes and curves downwards. To attaching the glenohumeral or the capsulohumeral complex to the edge is very important, not to the top or inferior, which can create trouble. It can reduce the glenoid tract if you are going over the glenoid edge, or if it is not tightly repaired, and the number of anchors is very important. So earlier days, surgeons used to say one anchor, you do a Mason Allen and tighten it, that's enough. That's not enough, absolutely no. You have to have the 3 anchors and all suture anchors always. For the youngsters, don't use metal anchors. We've seen enough and more problems with metal anchors. They loosen, they come out, there is a knob through which the suture passes. The tip comes out and creates trouble, and I've seen catastrophic wear of the humeral head due to prominence of the metal anchors.
Yeah, thank you very much. I think it's a good message what you gave. That I always keep telling that you would have, if you are doing 45 minutes of surgery, spend time in releasing the anterior labrum from where it is fallen off.
Yes.
And more time we have to take there, because sometimes we can't even see the labrum, so buried inside, deep inside.
You're right.
Very well said message. And what about the type of anchors between peak and now we get this biocomposites, bioabsorbables anchors? What do you prefer and why?
I started with peak, then I changed to biocomposite, which were good, the 2.9 or 2.4 or 2.3 biocomposites, but now I'm 100% all suture. Inside the shoulder joint, all suture. Even for rotator cuff, I'm 90% all suture. Unless the bone is very weak, I may change to a titanium anchor. But otherwise, it's all suture. They are good. I don't see problems. I don't have osteolysis. There are some reports coming about all suture anchors. But then, if the securing is good, it does not cause osteolysis. It heals well. And before the anchor can create any trouble, it heals well and is much better and safer than any hard anchor. The soft anchors, even if they come off, don't create more trouble. The soft anchors are very secure, they're very strong. The new generation, the all suture anchors are actually quite good. I use to take names, the Q-Fix is one of my favorite anchors, or the Iconics. The Q-Fix has this sheath which protects and goes in, and it does not malfunction. I have not seen that, yeah.
Dr. Sujit, 2 things from my side that I'd like to ask for discussion. One is, what would be the distance between your anchors? I mean, any rough guide for everybody? And the second would be, a lot of knotless anchors are being promoted nowadays, especially for the beginners, to make it easy for not handling, get all jumbled up. So what is your take on that?
About the positioning of the anchors, as I said, marking the anchor points are important, and the lowest anchor I would place around 5.30, and I use one thing I forgot to mention is a curved anchor insertion device. So always have that in the arboretum. Tell the company people to bring that in, because that's very useful for the inferior most anchor. Even for the other anchors, you can have a good positioning there. And always, after parking the anchor at the edge of the glenoid, always lift it up and lift it more inferiorly, so you get more angle and the humeral head will move out of your way. So don't feel that the ankle is very acute. You can park it there and lift it up and lift it up. The humeral head will go out of the way. You can very well, even without a curved anchor inserter, you can do that. So 5.30 first one, at every o'clock position you should have an anchor, and the uppermost anchor is at 3 o'clock, not proximal to that. So the rotator interval should be respected and left there. Anything above the MGHL will constrain the shoulder. So at 3 o'clock, 4 o'clock and 5.30. These are the 3 good positions I would suggest.
Yes, sir. There's a question.
Yeah, Vinay.
What about replissage? How many anchors do you use? It's a single loaded, double loaded anchor 1. 2, your inferior most anchor is double loaded anchor for glenoid. So rest the 2 anchors are double loaded, or it's a single loaded anchor, the rest of the 2 anchors?
To answer the second question first, the first anchor is double loaded, but usually especially when it's a straightforward Bankart, person 30-32, and not much of ligament laxity. I use single-loaded anchors for all three. And if I use a double loaded anchor for Bankart, it's only the inferior most. The other two can be single loaded, because otherwise you are making your life more complicated. So double load anchors are a little difficult to manage sometimes. So always keep it straightforward. Single anchors, you can use 4 anchors if the money is not a problem. You can use 4 anchors instead. Here, 3 anchors, you have space for 3. You have double load anchor inferiorly. And about the remplissage, I usually manage. It depends on the length of the remplissage. The breadth is the remplissage is what decides whether remplissage needs to be done. Breadth of the hillsides is what decides whether remplissage needs to be done or not. But then if the length of the hillside lesion is long, then we can use 2 anchors. Or if it's small, you want to do it faster, simpler, probably you can put 2 anchors and tie them and finish it. But what I follow is put a double loaded anchor and take 3 bites, 4th bite through the anchor hole and tighten it. And you can adjust the distance between the anchors. So you can bunch it up over that. And preparation again, as Dr. Prasad said, Dr. Rudra Prasad said, the cleaning of the area is very important to build back the lost stability on the hillside lesion.
So I think you covered almost everything, Dr. Sujit. Thank you so much. I think we can invite Vinay now. There are no more questions.
Sir, we have a question from the YouTube viewer, sir.
Okay, yeah, please go.
Dr. Mahesh Jahangir, I think the same question that Atik sir asked just a few minutes before. What is your take on push lock anchors or knotless anchors?
Sorry, I missed. I missed the answer. So I'm not a fan of that. But then you might think it is comfortable. But then when you take a bite and you apply it, you don't have a chance. You don't have a option to adjust. So your hands are tied. You already have the labrum in your hand, and the anchor is there, and that is more difficult for me than using an anchor first. You have more control. So you are in control where you are putting the anchor. In case the anchor malfunctions, I can take it out, I can put a new one. But when you are using the push lock, you are constrained and you don't have a hole, you have to go through that. If it malfunctions, you are lost. And then it makes trouble for me, and I'm trained this way, and I am comfortable this way. So I feel an anchor insertion with bites and tying the knot, it's not difficult. Tying knots, I feel, is a simple thing. You are tying knots on your shoelace every day, so it's almost like that. Yeah.
Sundar, you wanted to say something?
Regarding the knotless anchors, of course, what Sujit says that controlling the push lock, knotless anchors, always it's tough than the knotting, because knotting always you have a control, but the knotless you don't have a control. So even most of us, I use mostly double loaded for the inferior anchor, and the second and third anchor, most of the time I use knotless anchor. And the advantage of knotless anchor, you can have use a suture tape, and which has got a especially when you have if the cup is not good, it has got a good pull on that. It doesn't cut through much. And second thing is, when you use a knotless anchor, you should have enough leverage of the thread before you insert the anchor. So that is a trick. So you should not take the knotless anchor after taking the bite. So you cannot go directly to the hole. You have to lever at least once. You have to leave the thread of at least 1 centimeter where that has to go inside. Then you hammer it. Otherwise, what happens if you directly insert it through the hole? It pulls the whole labrum inside. It can tear, especially if the tissue is poor. So the technique you have to follow if you are using the knotless anchor, which is a little tricky, as Sujit said.
Okay, so are we?
Sir, Manish has already, I think it's a comment on your, whatever you highlighted in your presentation also, that he's saying that the anterior glenoid, we should avoid putting the anchor on the face of the glenoid, and posteriorly, I think it's more preferable to put it at the edge. I think he just commented on it. Thank you, sir.
If that's okay, should we proceed to the next talk?
Yes, sir.
Dr. Rudra?
Yeah, I think we can go to the next talk.
Okay, so Vinay,
Yes,
why
sir.
don't you talk about your step-by-step management of frozen shoulder? I think it's an excellent thing to be spoken about.
So can we see the screen?
Yes.
Yeah, we can see.
Thank you, Rudra sir. Thank you, Atik sir. Thank you, Sundar sir. So I'll talk about frozen shoulder. It's very commonly seen thing in the OPDs. And recently I heard somebody saying, some big surgeon and very senior also said he had never released frozen shoulder. So I think it's a very hot topic to be discussed. So the basic pathology in frozen shoulder is erratic increase in fibroblastic activity of the shoulder joint capsule. Everybody knows this. And the presentation can be of two types. It can be primary presentation, which is seen in diabetics, hypothyroid population, and an inflammatory polyarthralgia. And the secondary frozen shoulder is seen in injury, post-op, and post-op complication as a post-op complication. So various stages have been defined for frozen shoulder, which involves inflammatory stage, which can last up to 3 months, the freezing stage, which can last up to 9 months, and the frozen stage, which can last up to 12 months, and thawing stage, which can last up to 42 months. That means it can last up to 3.5 years. So it's quite a long process, can last up to 3.5 years. So it's a quite incapacitating kind of condition for a patient. So the treatment options are physiotherapy. First, it is the backbone of treating frozen shoulder. And then we have a steroid injection. It's best suited for stage 1 and 2. And mobilization under GA, I think a lot of work is being done on mobilization under GA, and few studies have come up of it by Ganga Hospital from Sundar sir also. It's a wonderful procedure. But for me, iatrogenic injury is a possibility, especially in the scenario of osteopenia, which is seen with this problem of frozen shoulder. And sometimes we can land up with a cuff tear by doing a mobilization the GF. The technique is not correct. An arthroscopic release, which is best suited for stage 3. So there are specific advantages and disadvantages of each of the techniques. Now, physio is it's easily accessible. Most patients respond to physio, but it's a painful long process. It can be a painfully long process. Injection, it's an OPD procedure, very cost effective, but it works only best in stage 1 and 2, not so good for stage 3. Now, mobilization is a low cost affair. No admission is needed. No arthroscopy skills are required. And it's a low cost thing. But risk of iatrogenic injury is there. And post mobilization pain is one thing which I'm concerned about. Now, arthroscopy is a procedure which is controlled, release under vision. Everything is controlled. You know what you're doing, but the surgical skills are required, and it is best suited for stage 3. If one is trying to do an arthroscopic release in stage 2, one should be prepared with a lot of synovitis, a lot of bleeding to happen, and it can be a struggle, really big struggle. So how do I proceed? Inflammatory stage, it is injection plus physio. Stage of freezing, it is injection physio again. So stage 1 and 2 are more or less same. Stage 3, when the joint is frozen, that means it is more of a stiffness than the pain which is present. So I go with arthroscopy. And the fourth stage of thawing, it is wait and watch. If I can see that the pain is not there and the joint motion is increasing, patient says that they has improved, I still wait and watch, don't do anything in the patient. So this is a case of 48-year-old beautician. She was quite incapacitated because of this problem, painful restriction of external rotation and abduction for 8 months. There was no history of injury. One can see there was hardly jog of external rotation present. Now that is the condition. She doesn't look to be very painful, but the external rotation was hardly a little bit. So she was hypothyroid, already took 2 injections. So these are the patients whom I see there is hardly any external rotation present, not so much of pain, and everything exhausted. Patient has done a lot of physio and injection has been given. Now, these are the patients which I think should be taken for surgery. And this patient was taken up for surgery. I divide my frozen shoulder into 9 different steps. First is shoulder entry, which is through the posterior portal. Then becomes the working port, which is the anterior port, the interval release, MGHL release, anterior capsule release, posterior capsule release, inferior capsule release, then fine-tuning the release, and confirmation of adequate release has been done, because one complication is you have released and patient comes back with pain again and again, stiffness if the release is not adequate. So out of all these 9 steps, 3 steps which are most important for me is entry to the shoulder joint. Stiff shoulder entry can be really problematic and it can be a really big struggle, and one can end up puncturing the humeral head if one is not careful with the trajectory of the entry to the shoulder joint. Again, interval release, one has to be really thorough with this. When there is no shortcut to release the interval, because as the interval is released, rotator interval, the shoulder joint opens up and it becomes easy to manipulate the other part of the shoulder joint. Again, the inferior capsule release is again important because of the proximity of axillary nerve to the glenoid rim. One has to be careful when releasing the inferior part of the shoulder joint. So regarding shoulder entry, one can use thinner profile rods to enter the shoulder joint because the space is not much. C-arm guided saline inflation of the joints can be done if one wants to. I don't do this. Slight manipulation, flexion is one manipulation which is safe and efficient. So I always do flexion of the joint and that's it. No rotation, no abduction. Just do flexion a little bit and enter the shoulder joint. traction devices are helpful. It is very important to be careful not to damage the cartilage. So the trajectory of entry to the shoulder becomes very important. So once you have entered the shoulder joint, one starts with creating the working space. So create the working space anteriorly by putting in a needle. So one can see that there is hardly any space. The space between the head and the glenoid is hardly any. So 16 gauge needle is more or less occupying the whole space. Then starts the gradual dilatation of the working port. One can put in the Wissinger rod, and on top of rod, the dilation of the anterior working port is done. Now the tissues are so hard that you don't need to put cannulas in a frozen shoulder. You just create that space, and this becomes a natural working cannula. So you do not need to put in the cannulas that we get for working. So once that is done, one has to spend time to remove the interval scarring. One side there is biceps, the other side there is subscap, on top is head, and the bottom is glenoid. Patient is in lateral position, and one starts with releasing whatever is there in the interval space. As you start releasing the interval space, the joint space starts opening up. It is very good to use RF device for this. One has to be really thorough with this. Initially, I don't use shaver because shaver can cause bleeding to happen in these shoulder joints. So it is always wise to be thorough, use RF, and be liberal with releasing the interval space. So once the interval space is released, one starts moving down, and the first structure that is encountered is MGHL. In the scenario of frozen shoulder, the MGHL is called like thickened MGHL. So one starts releasing the MGHL, and as the MGHL is released, one can see the subscap and starts going down. So that's how the MGHL is released, and the probe is taken down inferiorly to release rest of the capsule. So after the anterior release, one starts going inferior. Sometimes the capsule is so thick that it is not possible to take down the capsule in one go. So one can do one part of the capsule release and then come back and release the rest of the capsule thickness. So here some part of the capsule is being released, and now the probe is taken and rest of the thickness of capsule is taken down. Then it is important to see the muscle tissue to confirm about adequacy of release. It is only when one sees the muscle tissue that one thinks that the release is adequate. So anterior release is taken inferiorly. So anterior and anteroinferior release is done. Once that is done, the probe is taken to the posterior port, and the visualization port becomes the anterior port. So here the probe is coming, the RF probe is coming from the posterior port, and visualization is happening from the anterior port. Usually this part is not so difficult because the posterior capsule is usually lax, and again the same process is followed. The posterior release has been done and the probe is taken inferiorly, and posterior inferior release is mixed up with the anterior inferior release. So at the inferior part, the posterior inferior release comes and meets the anterior inferior release. One has to be careful here because one should be wary about axillary nerve here. The trick is to be staying close to the glenoid rim and keeping the face of the probe towards the rim. One should be very slow during this procedure at this point of time because axillary nerve can be very close to glenoid rim. So sometimes you can see the axillary nerve, like here we can see the axillary nerve. So it's not mandatory to see the axillary nerve, but in this case you can see there is axillary nerve very close to the glenoid rim. One can appreciate that the joint has opened up, a lot of space is there, and the working in the joint becomes very easy as the posterior inferior release is made to confine with the confluence with the anterior inferior release. After this, the fine tuning of the release is done. one can use the shaver at that point of time, or one can use the RF probe. It is important to look for some fibrotic band which is there, which is going to obstruct the post of physio later on, to take it off and smoothen out the release process. Shaver or RF can be used. It is important to visualize the muscle tissue after the release has been done. Then only the adequacy of release is confirmed. One can appreciate that the movement of shaver is quite free in the joint and quite a good amount of release has been done. It is just to make sure that we can see the muscle tissue and the release is adequate. And last is to assess the release. The traction is applied, the joint is opened up to see muscle all around. So starting from the inferior part to the posterior part to the anterior part, one should be able to see muscle tissue. And that's how the adequate release has been done. This patient opted to get the right shoulder release as well. One can see this is the MGHL. Normal MGHL is very flimsy, kind of embracing the subscap. Here it was fibrotic. The same patient had the right shoulder operated. And again, this was the space which was there, hardly any space in the joint. This is the lateral which is occupying the full space in the shoulder joint. And after the release on the right shoulder also, this was the condition. You can see muscle all around. And it was a good release in this right shoulder joint as well. So that is how you have to go step by step, release every part, start from the anterior part, go to inferior part, then go to the posterior part, inferior part, and then confluent posterior inferior to antero inferior release. So that is how the release has been done. This is the patient. It is more or less a 1 year follow-up of this patient doing activity or daily living. Now the frozen shoulder is something which is very incapacitating for females as such, because a lot of their activity or daily living are hampered. And if a patient is exhausted by doing a lot of physio, taking injections for the shoulder, still not improving, one can go ahead and shorten the amount of suffering of the patient, because a stiff shoulder is a very, very painful condition. And if we can do something about the patient to cut short the problem, it's not a bad idea. This patient did very well, both the shoulders, doing all the activity or daily living. She's a beautician and she was not able to perform the activities. So I think it's important to go for releasing the frozen shoulder after all the exhaustive methods of conservative management have failed. So the take home is physio is still the mainstay. Steroid works for best for stage 1 and 2. Now arthroscopy is gaining popularity and fixed frozen shoulder, which means there is jog of external rotation or absent external rotation with abduction is there. One can think of doing an arthroscopy. But the patient is exhausted with physio, failed previous manipulation and injection has a history, then one can think of doing arthroscopy. And mobilization is still popular, but risk of iatrogenic injury is there. Thank you so much.
Thank you, Vinay. Nicely put forward. Any questions?
I have a question, sir.
Yeah, Terence, please.
A very nice stepwise and very nicely shown capsular releases. There one thing on a frank note, actually, can we actually call it capsular release, or is it like we have to do some amount of manipulation at the end, especially for getting abduction? I think Sundar sir also would agree that we never get abduction only with capsular release, and at the end, some amount of manipulation we have to do it towards the end to get abduction at least. And sometimes when the internal rotation is restricted, we also require a posterior capsular release as well. What's your take on that, sir?
Correct. So I think Sundar sir has a wonderful paper published, I think last year, about mobilization under GA for frozen shoulder. I think he has stopped doing arthroscopic release because in my head, I think it's not a very good, I am very scary of getting some fracture because the bones are really osteopenic. I'll tell you about my initial experiences. Once or twice, I could enter the humeral head when I was trying to go inside the shoulder joint. So it's a very risky affair, being a very osteopenic kind of presentation. As far as abduction is concerned, for me, if it is more of a external rotation, problem, then I go with the anterior release. And then if it is an abduction problem, I really go very deep and be aggressive with an inferior release also. I do take care of axillary nerve, but inferior release for me is very important. Posterior release, usually patient keeps his arm in internal rotation, so the posterior portion is not so contracted usually. But if it is contracted, one has to go and release that part also. So if it is like 270-degree release, which I do, and the manipulation only I do at the beginning, doing little bit of flexion, so that I could gain some amount of opening of the joint. Rest, no motion I do.
Yeah, Sundar.
Nay, so how often you go through, after doing all the releases, how often you do through subacromial decompression? Because sometimes we see some anterior to subscap, and you can see the lot of adhesions when you go through the subacromial area. So we try to do some of the decompression even anterior to the subscap. So do you do subacromial decompression at all, or you don't?
So initially to start, I was doing both the releases, intracapsular as well as subacromial. But last, I think 1 year, I have stopped doing subacromial because I could not see too much of a difference not doing subacromial decompression. So right now, currently my practice is doing intracapsular release only. I have stopped doing subacromial. Initially to start, I was doing subacromial. So now I'm not into this subacromial decompression.
Yeah, Siddiqui.
How to prevent dislocation following arthroscopic capsular release? Because we have released all the ligaments. Is there any chance of dislocation?
So that is something which is very surprisingly, you release everything. This stiff shoulder never dislocate. So I don't think anybody from the panel, I think Sundar sir and Sujit sir can guide us. I think they would never have seen a stiff shoulder being released and then dislocated. So they are again become like new fibrous tissue forms there, and these shoulder joints stabilize themselves again. So it's not like that there will be no capsule. After a point of time, some fibrosis will happen, some fibrous tissue will form, and the shoulder will stabilize again. So Sundar sir and Sujit sir, what's your take?
Sujit?
Yeah, no, I had a different question. Yeah, definitely, yes. This is actually the opposite of bank cut. We are trying to repair something there, you are cutting off everything in here. So that's the first question which comes to our mind, but then it never dislocates. Basically, the muscles and the tissues are all tight, and the patient is usually about 40, 50, 60. So the dislocation chance is never usually there. One other thing, one point I want to bring in is when do you do the releases? So in the first part, with the inflammatory phase of adhesive capsulitis or frozen shoulder, if you try to do, I burned my fingers, it becomes a messy affair. You cannot just enter the joint sometimes. I've got stuck, and then usually you have to wait for the thawing phase, and then when it is tight, you go in. So avoid that. That is one important thing. And if you are not able to enter, what do you do? Like posterior, if you are not able to put your scope inside, it's too tight, then how do you go forwards, Dr.
Manipulation.
So let Vinay answer, and then Sundar, you can give your take.
So besides the 3 or 4 methods which I apply, one is using a thinner bore Wissinger rod, very thinner bore Wissinger rod, which I use. And initially I was not keeping it, and then I heard it somewhere and I started using it. That has made my life very easy. And this Wissinger rod little sharper ahead, and one has to be very, very careful of trajectory. With these sharp instruments, sharp Wissinger rod, which can penetrate the capsule, but if the trajectory is not right, you will end up in the humeral head, causing a puncture to the head. So luckily, I have not faced the scenario currently where I could not enter the shoulder joint. Yes, I do take your point. If one tries to do a release in stage 1 or maybe in stage 2, where there is a lot of synovitis, it's a very messy affair. So one has to wait, and I always take the patient, if patient has got 1 or 2 shots of steroid injection in the shoulder and does a lot of physio has been done, then only I take patient for surgery. And luckily till now I have entered the shoulder joint. Someday I'll maybe
one point I would like to bring in there is one method is to go from the rotator interval. That is, you start subacromially, go through the rotator interval, release the anterior structures, and then you start with the release anteriorly, viewing from anterior superior portal. That is one way you can enter the joint and then start doing the releases from anterior.
I think it's technically it will be very difficult, because like experienced surgeons like Sujit can do. Generally, because people got used to enter from posterior, then you see anterior, because we are not used to see anterior first. So it's very tough, especially in a stiff shoulder. I think panel will agree that even I had seen my cases. I will see sometimes a hole in the humerus. Then I see why the hell the hole came. Then in my first case, I realized later on, okay, this is my trocar caused this issue. It is not the first occasion. Of course, I had a few occasions. I think many of you might have had this issue. There is no, because when you talk about complications where you told about osteoporosis or osteopenia, this is also one of the complications. When you have an osteopenia, when you have a stiff shoulder, when you are not able to enter, and if you put a trucker, you make a big hole in the humeral head. That is also true. So I think, as I said, I'm not talking about the paper or something like that. Of course, it's a capsule is a wonderful procedure. Still, I do also. I mean, when I said I don't do, I do also. As I said that if you are feeling very tough, you do a slight manipulation, it gets opened up. Then you go and see and do. There is no. It doesn't mean that if you do a small manipulation, you will get everything is messy. You just clear it in 1 minute. It's like an acute ACL when you do in a first week, you get messy. Then within 1 minute, if you clear all the blood, everything is clear. The same thing happens here also. Maybe they want to avoid this iatrogenic injury. Just I'm giving you the tip. You do a slight manipulation, then you get joint gets opened up, then you do a release also. If you're worried about that puncture, it can happen.
Doctor,
even if you use a missing rod, I also use missing rod when I'm not able to. If I find very difficult to enter, I use the missing rod like what when I said. That's a good technique.
There is a question in the YouTube channel. Someone is asking whether frozen shoulder is a good starting case to learn shoulder. So we absolutely not. This is the most difficult surgery to be done. Dr. Vinay demonstrated as a simple procedure, but this sometimes can be the most difficult one.
Dr. Rudra, Dr. Terence, any comments?
Yeah, it's a good message. I think one important thing is before taking the patient for surgery, I think to take them with a good physiotherapy. That's the most important thing. And is not a commonly done procedure at all. And it's a very rare surgery. In fact, even high volume surgeon, a year maybe they do very few cases. I don't think so. It's a commonly done procedure. We take a lot of pain. Minimum 6 to 7 months we wait. Diabetics, they don't respond so early. So exercise is important, physical therapy is important. Half of the time, most of the people, they would have stopped doing exercises because it is started hurting. It's very painful. And what I do is clinically, when I ask them to show the exercises, what they're doing, important thing to me that, indication for frozen shoulder has to be very clear. They should have done good exercises for a good time and still it is not, having any results. Then all these technical aspects, whatever we discussed, very well shown by Vinay. I think it's very important. And as Sundar said, I think whatever release we do, at the end of the procedure, we have to do some manipulation. It will not just heal just like that. Because we have to understand it's called periarthritis before frozen shoulder. Periarthritis means it is a disease of every structure around the shoulder. It doesn't dislocate. It doesn't dislocate because what we are releasing is just the capsule. But the muscles around it, everything is stiffer. And they allow the joint to dislocate so easily. That's all I wanted to say. Very well done, Vinay. Thank you very much.
Dr. Sujit, there was a question on your previous this thing that how much would you go? I'll just read out the question to you.
If an anchor comes out, isn't it?
Yeah.
So how far would you insert the next anchor? So first of all, I would say it's just not coming out of the anchor. You have to plan and see why it came off. It could be usually, for me, the anchor has come off whenever I try to view from posterior and try to insert the anchor there, because you are not going into the bone, one. So you have to assess why it came off. It might be a wrong trajectory. So if that is a wrong trajectory, you can correct it and insert at the same point. You have to view from anterior, see the edge of the glenoid, as I said earlier, twice I said, because that's the most important. That's where I went wrong many times. And then when you look from above, you can see the edge and put it there. Then if an anchor comes off, if the hole you created, or the drill hole has not malfunctioned, the hole is the same, then if there is something wrong with the way you crumbled it, it didn't crumble inside, just came off, then probably you can insert an anchor there itself. And if you have made a bigger hole, if the bone has cracked a bit, if you have not had the trajectory perfectly, you cannot put an anchor there, then you can leave a space of around 3 to 4 millimeters on either side. and then you can use a double loaded anchor, so that can take care of the anchor place where you had already planned, as well as the area inferiorly or superiorly. So 3 millimeters is what I would usually suggest, 2 or 3 millimeters, a good bone bridge, Dr. Sundar. And you can go in a different direction as well, a curved anchor in a different direction. Dr. Sundar, please.
The other option is like what Sujit is doing, like if you do all inside, it can be converted into your peak or a bio screw into bigger diameter, and the same hole can be used and it can go slightly deeper. I mean, so because all inside doesn't go that much deeper than like what you use for like peak screws, and because your diameter is also bigger, so same hole can be used if you are using an all inside.
Good suture. Okay, so if you are done, can we go to the Terence? Anything?
Yeah, Vinay sir, actually one question for you. They are asking how often do you see stiffness reoccurring after the release? And what is your regimen for post-op pain relief in cases after doing these capsule releases of frozen shoulder?
So initially when I started the practice, I was very kind of conservative in releasing also. So even if little bit fans or bands are there, I was not releasing, and I was conservative. So initially a few cases I did get a lot of problems, and intra-articular injections after release also I used to do. But off late, last 1.5 2 years, I've been very aggressive. When I release, I just don't think and just keep on releasing. So as far as I can see the axillary nerve also. So now routinely I can visualize. It is not mandatory, but routinely I can see axillary nerve. So last few cases, I think I am quite lucky not to get so much of stiffness, post-operative recurrence of stiffness. Initially, few cases that was a problem with me. So it's important to release adequately to visualize muscle all around and get on with physio next morning. So if you delay, immobilize, not doing physio, just next morning onwards, it has to be aggressive physio. That's the crux of it.
Okay.
Very honestly put, Vinay. So should we go on to the next talk?
Yes.
It's done. Okay. Can I invite Dr. Siddiqui to speak on autologous minced cartilage implantation? Dr. Siddiqui, if you can share your screen.
Good evening, everyone.
We can't see your screen, Dr. Siddiqui. You'll have to go to the share screen. And, yeah, no, that's okay. Can we start? Good, wonderful.
Good evening, everyone. At the outset, I would like to thank Sundar sir and IAS team for giving me an opportunity to talk in this webinar. My name is Mozimul Siddiq. I am from Karnataka. So this is a case of recurrent dislocation of patella with chondral defect of the medial patellar facet, which was treated by autologous minced cartilage implantation along with MPFC advancement. I have nothing to disclose for this talk. A 29-year-old zonal badminton player presented to us with the complaint of anterior knee pain. He had 2 episodes of patellar dislocation. First episode was 10 years back, which was associated with fracture of the medial facet. It was treated conservatively. Second episode was 6 years back. At the beginning of this year, he had 2 episodes of subluxation, which was treated by physiotherapy and muscle strengthening exercises. On examination, patient had a positive apprehension sign at 30 degrees of knee flexion. Medial lateral patellar glide was increased, indicating to some kind of medial soft tissue laxity. Gaze sign was negative. Alignment and rotational profile of the lower limbs were normal. AP and lateral X-ray of the knee at 30 degrees of knee flexion was along with the merchant view were taken. This is the scanogram of the patient showing normal alignment. MRI showed full thickness focal cartilage defect of the medial patellar facet along with old united fracture of the patella. MPFL was intact, was seen in all the section in its entirety, although it looked little stretched for me. The TTTG distance was 16 millimeter, trochlear depth was 4 millimeter, insult salvati ratio was 1. CT scan showed united fracture of the medial facet with cortical irregularity. So we took him for diagnostic arthroscopy. Full thickness chondral defect was noted on the medial patellar facet along with the fraying of the surrounding cartilage. We plan to harvest few cartilage chips from the medial and lateral borders of the lateral femoral condyle using a shaver. However, the shaver was the Excalibur one, soft tissue shaver, so we could harvest 0.5 cc of cartilage chip. So the plan B was to harvest the cartilage chip when we are planning for MPFC advancement. So we went ahead with the medial patellofemoral complex advancement. Our medial parapatellar incision was given. After the incision, 3 structures were identified: quadriceps tendon, vastus medialis oblique muscle, and medial retinaculum. The musculoretinacular layer should be separated from the capsulo-ligamentous layer. That is the next step. So we can, this is the right leg, this is the head end, this is the foot end. You can see the medial patellar retinaculum being separated from the underlying capsulo-ligamentous layer. It is very important to start the dissection inferiorly, as there is a space between the layers. If you start superiorly, the layers are indistinct and it is very hard to separate. The dissection has to be meticulous and gentle. So we can see here the VMO muscle and retinaculum. So this is the musculoretinacular layer. This is being tagged with the number 1 vicryl. This is also a very important step because while closing, we should not mix up the layers. The next important step is to cut the capsule very close to the patella, just like a subperiosteal elevation. While cutting, we should not damage the trochlear cartilage or the patellar cartilage. Again, we have to be very meticulous and gentle. So this will lead to the orthotomy and visualization of trochlear cartilage and the patellar cartilage defect. So on eversion of the patella, we can see the defects over the medial patellar facet. Now it is important to prepare the shoulders of the lesion with number 15 blades so that they are made vertical. Okay, and the base of the lesion should be curated with the curate. Another important thing here is never to do a microfracture. So just curate it and prepare the bed. So we harvested few pieces of cartilage from medial and lateral borders of the lateral femoral condyle using a blade and a curate. And this is the way we minced it. We put it in a saline, in a glass bottle, sterile glass, and we use the shaver to mince the cartilage chip. And this is the graft net device used to collect the minced cartilage. So around 3 cc of minced cartilage we could collect. Then we prepared the autologous conditioned plasma by collecting 16 ml of patient's blood using a double syringe. This is a double syringe, and we spun it for 5 minutes at around 1500 RPM. And this is the inner syringe having a ACP. So a few ml of ACP is mixed with the minced cartilage. The advantages are like it helps in the cartilage chondrocyte proliferation. So after that, 2 5.5 mm fully threaded double-loaded corkscrew anchors are used in patella. After that, patella is again everted and minced cartilage is applied using an applicator. And then it is stabilized with a fibrin thrombin glue. The setting time of 10 minutes is allowed. Threads of these are passed through the capsule. The exact location is 2 cm from the cut edge of the capsule, and they are tied. Each tied in a matrix fashion. And they tied from inferior to superior direction. Single sutures from this combination is passed through the anterior soft tissues of the patella and tied with the respective sutures. After that, musculoretinacular layer is closed. Again, it should be closed not very tightly. The post-op protocol is like partial weight bearing for 4 to 6 weeks. First 2 weeks, 0 to 30 degrees. 2 to 4 weeks, 30 to 60 degrees. 4 to 6 weeks, 60 to 90 degrees. Full weight bearing from 6 weeks. This was the follow-up at around 6 weeks of time. Patient had a movement of 0 to 90 degrees. Now the patient is able to walk without any signs of instability and without any pain. Few words about the chondral injuries of the patella. The chondral injury of the medial facet typically occurs not in the dislocation stage, but in the relocation stage. During relocation, we can see the medial patella collides with the lateral trochlea, and the medial patellar condyle or lateral trochlear condyle injuries can occur. Autologous minced cartilage implantation is a single-step procedure. Small as well as large chondral lesions can be addressed. How large a lesion can be addressed is not defined. Adult chondrocytes are in post-mitotic stage. Chondrocytes are activated by mincing. Mincing can be done by a scalpel or mincing device like a shaver. PRP is beneficial for chondrocyte proliferation. Fixation is via fibrin-thrombin glue. Few words about shavers. This is a designated device like a 4 mm bone cutter shaver or 4 mm saver cut device should be used to harvest the cartilage. Other like the torpedo or Excalibur shavers are soft tissue shavers. They are not advisable to harvest the cartilage. And also this is the graft net device which is used to collect the minced cartilage. So approximately 10,000 chondrocytes are there per cubic millimeter of a chip. 1 square centimeter of defect contains about 250 chips. That's approximately 1 million of chondrocytes. So why we chose medial patellofemoral complex advancement over MPFL reconstruction? MPFL advancement has got both static and dynamic components. It is devoid of multiple technicalities of MPFL reconstruction. It does not require intra-op imaging. We are not harvesting any hamstring tendon, so there is no graft-like morbidity. There is no, we need not modify it in pediatric patients with open physis. So MPFL reconstruction has got a steep learning curve. Any deviation of femoral tunnel by a mere 5 mm results in anisometry. So we are all well aware of Shuttle's point. This is the posterior cortical line. This is the line along the posterior border of the Blumenstadt line. One more line will come here along the posterior border of the medial femoral condyle. The Shuttle's point will be 1 mm anterior to the cortical line and 2.5 mm and distal to the medial femoral condyle line. This is actually the Shuttle point. If you put it little proximally, we can see here in extension it is normal, while flexing it becomes tighter and it will not allow the patella to slide in. So as a result of it, there will be wrong range of movement deficit. Similarly, if you put it little anterior also, same thing will happen. So this is the paper by Prathamesh Jain sir, which has elaborated on the MPFC advancement and its advantages. This is the paper by Jan Salzman, who has advocated minced cartilage procedure. So the take-home message is follow the cartilage repair algorithm. A la carte approach is ideal. Avoid MPFL reconstruction with cartilage procedures of patella, because if you do MPFL reconstruction, it will lead to excessive stresses on the middle patellar facet, ultimately leading to the failure of the procedure. Thank you so much for your patience.
Thanks, Dr. Siddiqui. Is there any questions? Dr. Siddiqui, any particular size of the lesion which you would consider going? I mean, you have a guideline where you would consider doing, wouldn't do or would do?
Sir, it's still equivocal, sir, for minced cartilage. They say you can do it for from small to large lesions. They have not defined any sizes. Unlike we usually take less than 2 centimeter microfracture, 2 to 4 centimeter, like more than 4 centimeter. It is not, we can do for any lesion. That's what they, Jan Salzman has advocated.
You are sticking this, you think doing this only for the patella, or you tried it somewhere else also?
We did it only for the patella, but it can be done to the femoral condyle.
Okay. So you can see a definite advantage there if you can.
What the literature says, Moshibul, like do they have a short midterm follow-up of these minced cartilage procedures? Have come across?
No definite, no equivocal results. Like still there are researchers, I mean, there are papers coming up. They have not pinned down that this should be done, or like we can do like scaffold based or other things also, sir. Whatever procedure regarding the minced cartilage, still the papers are coming. It's a new.
What is your longest follow-up? What you have done?
It's roughly 3 months, sir. So we want to do a repeat MRI and relook, planning for relook later, sir. As of now, patient is asymptomatic. So
okay, it's much better. So
what is the reason now? Sorry. Okay, go ahead.
Yeah, continue. Please, Dr. Rudra, go ahead, please.
No, I just wanted to ask, whether what was the reason why you didn't do a microfracture? Is there any specific reason?
The microfracture leads to fibrocartilage, which we all know that it will deteriorate over time, like 6 months to 3 years or anywhere. the fibrocartilage will deteriorate, and again it will. It is a short time relief, the microfracture. It is not a long time thing. So ideally.
Well, anyway, I think this minced cartilage, whatever you're producing, I think this is another question we are all in search of an answer. Yes. We still don't know whether it is going to a definitive hyaline cartilage. And I think patella should not be a problem because patella is not a weight bearing. But most of these patients land up in patellofemoral problems, whatever we do, whether it's a microfracture or a minced cartilage or whatever. And I think if I'm correct, did you approach this patella through medial approach?
Yes, sir, medial approach.
On the medial
yes,
side.
Sir. Because we wanted to advance the retinaculum, capsular layer. So that's why.
The age of the patient was, in this case? 29. And now, because you have gone through the medial side, but you have repaired the medial patellofemoral ligament very well, repaired it after the incision.
Yes, sir.
So that you're not bothered about, I mean, you're not definitely worried about the patella instability in this case.
Yes, sir. True, sir.
Anyway, I think I don't have an experience with this procedure, but hopefully we get some answer.
We want a long-term follow-up.
Yeah, do let us know.
I think it's very creditable to you, Dr. Siddiqui, because I think this is the answer we all are looking for, trying, cartilage regeneration and trying to get it. I think I must appreciate your effort. And I think we should look forward over the year to see how your results come out, and all of us can benefit from that.
Thank you.
If there are any other questions?
Yeah, in YouTube, sir, just to...
Dr. Terence, please.
Yeah, to Vinay, sir, actually, they have also asked you regarding your post-op management. How do you manage your cases after capsular release for a good outcome? That is one thing. And another candidate, the delegate has already asked 2-3 times on a different question on ACL reconstruction. They have asked your opinion from all the panelists, saying a lot of times we get post-op laxity at 6 months. How do you address, how do you counsel the patient, and does it actually mean that the ligament is lax, or is it because of some reason? So they wanted an advice from all the panelists.
So first is frozen shoulder. I think what I do is I forgot to tell, because in every case you have to tell patient from frozen shoulder, it's not daycare procedure. So the patient has to be there in the hospital for 3 to 5 days, put an intrascleral block. And that is how initial 3 to 5 days with the block, it is important to mobilize the shoulder. Otherwise, if you don't give that block, initially I was not giving the block. So patient, even after capsular release, to mobilize the patient next morning becomes very difficult. He will not cooperate. So if you put a catheter, keep the pain control there, then you can mobilize, and 3 to 5 days mobilize, and then it becomes very easy. So that is one thing is, whenever doing a capsular release, one must try to keep this in mind, to give intrascleral block and keep it there for 3 to 5 days. And regarding ACL, I think Sundar sir and
I think residual laxity, because when you started doing more and more hamstring, we started seeing that residual laxity. There are possibility whether, because there are other reasons also can happen. Suppose if your button is not engaged on the bone, if it is engaged on your iliotibial band, again that can give us some laxity of the ACL. I think further post-op X-ray will be helpful. But whatever you see, you are not going to see on the day one. You are going to see on the end of the 6 months time. By the time patient might be walking freely without any pain or without any discomfort, and we are not going to do anything for the laxity as per se, unless patient comes back with any failure or instability. And if you want to do come back with the instability, then you're going to repeat the MRI scan to see any failure. If there is no re-rupture, and we are not going to bother, you just do a quadriceps rehabilitation, reassure the patient, and don't tell the patient that you are having grade 2 to 3 laxity. You say that patient has got a mild laxity. That is quite common for this kind of graft if you are using a hamstring graft. Then we have to just reassure the patient this is normal, because ACL is not a very stiff ligament, first of all. I think even when you fix it up, you should not fix it very rigidly. You should have 1 or 2 mm laxity. So that grade 1 usually will not give any issue, in my opinion, because we tend to see many patients with 2 mm, 3 mm laxity when you examine them at around 6 months time. So just reassure, rehab. I think that should be fine. If any other opinion.
but just question, Atik sir.
Yeah.
Rudra sir, for you and Sundar sir also. So I have never used this PTB and compared kind of PTB stiffness post-op, maybe Lachman or maybe this hamstring. So in, anybody who has used both the graphs, is there a difference of clinical Lachman using hamstring versus PTB 6 months down the line?
Hamstrings are more lax, definitely, as compared to the PTB. There's no doubt about that. And down 6 months down the line, you do get. One thing what Sundar said, I would just like to add that you have to make sure when you do your primary surgery that you've not missed anything. Other reasons for laxity should not be missed. Your ramp should not be there, or ALL and all that, whatever whether the patient has a explosive pivot shift and we have not added any LET or whatever we want to add. So all those things have to be looked in before it's just can't say that it's just a simple plain ACL. So if it's just straightforward ACL without any other factors, then I think 6 months down the line with the hamstrings, you were getting some amount of laxity. And most important thing, I think what Sundar said was your ACL is not a rigid structure. It's not like a stick inside. It's got some amount of play in it. So initial tendency even for me was to feel very proud in saying that it's so rigid, but it always created problems in mobilization post-op. A little bit of laxity initially also when we do, I think the post-op rehab becomes much better, is what I feel. What about the rest of it?
Yeah, one thing to add would be when you compare hamstrings and BTB, hamstring is a little more forgiving because it can stretch out by a millimeter, but BTB won't.
They'll never stretch.
A rigid structure, you fix it, it's there, it won't move. So that is the reason we use it for people with ligament laxity. So hamstrings can stretch a bit, and as Dr. Sundar said, it's a lax structure always. That's why hamstring probably is the favorite graph for most surgeons.
Okay, we had used PTP for the 2000 maybe 4 to 10, 9. We are using only PTP at the time. Of course, this kind of laxity even I have not seen. Like what Atik said, naturally that is more stiff graft than the hamstring graft. So, but we don't clinically. Literature had proven, and we had seen our experience also that there is no huge difference between either PTP or a hamstring graft, whichever you use. So of course, technically it's more demanding when you are using a PTP graft. That also you have to keep it in consideration. If you are using regularly, it doesn't matter because we have done many years. But if you are starting, then yeah, I think. But you should learn. Of course, we require for your revision cases or other procedures. But definitely, it's technically more demanding. But it is well accepted that laxity is well accepted in the literature also. So we don't need to worry about it.
Yeah, agree with Sundar that I have done a lot of PTB in my initial days. Definitely, for nearly 4 to 5 years, we were doing only that. And those days, we never had this transportal. It was a transtibial, in fact. And we used to see very less chances of laxity. In fact, still now, I prefer PTB for a very active, rugged sports guy. In fact, some of the patients come demanding for a PTB. I'm very happy to do that because it's so reassuring. And it's a very strong graft in my book. It's a very strong graft, and the laxity part is much, much less. And again, as we discussed, laxity part not to be taken so seriously in the post-op, especially in hamstring. They don't have instability. They may clinically, when we do this anterior drawers, they may, but pivoting will not be there.
Yeah.
I think that covers almost anything. Anyone else has any other comment to make? Terence, anything else? Any other question?
I think we have covered all the questions on the YouTube, sir.
So, okay. I think I'll thank everybody.
Yes.
Yeah, Sundar?
Yeah, no, you can thank everyone and conclude.
Thanks to the speakers. Thanks to Sundar. Thanks, Terence. Thanks, Sandeep. Thanks, Dr. Rudra. And I think an excellent session. Let's look forward. I think, Sundar, we need to have some more of these. So, okay, guys, good night and have a good weekend.
Thank you.
So, thank you, Sundar.
Thank you, sir.
Thank you.
I'll end the meeting.
Yeah, thanks, Sandeep.
Yeah, Sandeep, please.